Hi, everybody. Welcome to your neuroanatomy lecture series. Today, I'm going to be covering some of the basic neuroanatomy that you'll need to become proficient at some of the more complicated things you'll get to later on in the year. Trust me, it does get very complicated. Today, we're going to be covering brain, spinal cord, and brainstem anatomy. Now, this is covered across 2 or 3 different lectures, but because of the significant overlap, I've decided to combine them just because it creates a bit of a better flow. And I think that you will benefit from just seeing all of this together in the same context. As always, I've linked the notes that I've made on Notion in the comments below. So if you do need any extra information, please refer to that. But otherwise, this lecture by itself should be all encompassing for at least the basic content. So without any further ado, let's begin. So let's start with just a little bit of basic neuroembryology. So I know not everyone likes the idea of embryology, and really for the neurological system, it's not as relevant as, say, for example, the gastrointestinal system, but I would say it's still quite relevant to understand some of the basic divisions of the embryological system when it comes to the brain, spinal cord, and some other parts of the CNS. So there's only 2 slides on this. I'll be really quick. The first stage that I want you to be familiar with is the idea of neurulation. So that occurs between the 3rd and 4th weeks. Again, these dates are not important, but it's just a good idea to know roughly when this happens in the scheme of everything else you've covered. What you end up having is firstly the notochord. So as you can see in the diagram on the left, you can see that you've got a notochord and that appears within the trilaminar disc. Hopefully at some point you've covered the different layers of the trilaminar disc, the bilaminar disc, but within the mesoderm, you get this notochord forming and it tends to secrete some growth factors. Why does it do that? Well, the point is so that it stimulates the overlying ectoderm. Remember, you've got ectoderm, endoderm, mesoderm. So the overlying ectoderm turns into neuroectoderm, and then it thickens into a neural plate. So that's that purple tissue here at the top. And you've got these divisions of the neural plate. So you've got the lateral edges, which rise to form the neural folds. And then you've also fused in the midline to form the neural tube. So that's kind of what it's showing here. So those lateral edges come together more closely, and eventually you get them sealing off in the middle to form the neural tube. And then over it, you've got the neural crest cells. Okay, so they form this distinct layer. And then within each section now, you actually, like each of these parts will then give rise to a different cell population. So the main 2 things that are the progenitors are the neural tube and the neural crest. So from the neural tube, this purple section, imagine just some of the more central things that you have within the CNS. So the brain, the spinal cord, you've got the neural part of the pituitary gland. Remember that the other part is a hormonal, which is the anterior pituitary. You've also got the motor neurons, and then you've also got the retina. So I guess you could call them the main characters in the CNS all come from the neural tube, and it kind of makes sense because it's the central tube. The neural crest gives rise to mostly everything else. So you've got the peripheral nervous system, the adrenal part of the medulla. Remember that it contains your some nerve cells, right? You've got melanocytes, which are actually surprisingly part of the CNS. And you've got the craniofacial skeleton, which you may or may not have covered some embryology for already. Now, again, just to really clarify what I mean by peripheral system, remember that includes things like the Schwann cells, the neuroglial cells, the supportive cells of the CNS. And you've also got the sympathetic, parasympathetic nervous system, as well as the dorsal root ganglion, which should be all familiar terms from back in year 1. But if it's not, again, feel free to look at the notes in the chat to be able to kind of get an idea about what that means. The second part of this is the cranial development. So remember that in this neural tube, you've got a cranial end, you've got a caudal end. The caudal end is not that important for our learning. The main important thing that's super high yield is going to be the cranial end. So remember that the brain and cerebellum, the 2 major parts of at least the upper part of the CNS, they form within the 4th and 5th weeks, right after neurulation has just happened. And you get these swellings, which are called primitive vesicles. Essentially, that primitive vesicle then evolves into a secondary vesicle. And the main important thing is, as a general formula, these secondary vesicles then go on to form a neural component and also a cavity derivative. So again, general formula, all of these embryological structures, they form a neural part, so part of the CNS, and then a cavity that it's associated with, generally a place where you get being produced. So the 3 main sections I want to focus on here are the prosencephalon, let me say that again, prosencephalon, mesencephalon, and rhombencephalon. So again, encephalon meaning sort of brain related, and then the suffix being just relating to the different sections. So prosencephalon, an easier way to kind of note it is the forebrain, right? So that includes the telencephalon and the diencephalon. So telencephalon is the cerebral hemisphere. So literally what makes up the bulk of the brain, right? The two hemispheres of the brain. And then sandwiched between them are going to be the lateral ventricles. Now, this ventricular system, which I'm going to be referring to now and again, this will come up in a lot more detail later on down the track. So you don't need to have a good idea about it yet. But if you do want this to make a little bit more sense, I would recommend looking at a diagram of the ventricles, the system that produces the CSF, because the brain components and the cavity derivatives are so closely related, it's really impossible to study one without the other. Then you've got the diencephalon, which is composed of the thalamus, hypothalamus, retina, and the third ventricles. The mesencephalon essentially corresponds to the midbrain, which consists of the midbrain and the cerebral aqueduct. So we're working our way down. And then you've got the rhombencephalon, which is all the way down at the bottom, which is the hindbrain. That consists of the metencephalon and the myelencephalon. And these are, I guess, the least important ones. So metencephalon includes the pons and the cerebellum, as well as the upper fourth ventricle. And then the myelencephalon includes the medulla and the medulla oblongata and the lower half of the fourth ventricle. Again, this part is probably less important. I would kind of spend my energy trying to remember more of these top two ones, especially the top one, because you will be seeing a lot more of these terms come up when we discuss the adult derivatives of each of these structures. So again, if this is confusing, that's okay, but just try and have an idea about why we structure these in terms of forebrain, midbrain, and hindbrain, and what each of those refers to. Okay, now let's get to the adult anatomy. So looking at the brain, let's not really focus on the brain as such right now. We're going to look at the meningeal layers. In the same way that when we get to the cardiac system or the heart, we try and work our way from outside to inside. So looking at the thorax first and then the rest of it. So you already have a good idea about the skull from your head and neck lectures. So that shouldn't be a problem. But once we get a little bit deeper, we want to focus on the meningeal layers. So the coverings of the brain. Now, there are three important layers to be mindful of. And if you need a mnemonic to remember the order, DAP. So DAP is a good one. So the first one, the outermost layer, is known as the dura mater. Now, whenever you think about the dura mater, think about it as being a very thick, like very, very thick and tough layer. So thick, tough, and inextensible. It has two layered sheets of connective tissue. The periosteal layer, as the name suggests, so osteal being bones and peri being right next to. So periosteal is the one that is closely attached to the bony surface. And then underneath that, you've got the meningeal layer, which is connected to the spinal cord, or it's continuous with the meninges of the spinal cord, but it's just a layer underneath the periosteum. Between them, and the reason why the layers are so tough and inextensible is because sandwiched between them, you have the dural venous sinuses, which we will cover later on down the track, are going to be the structures that drain the brain parenchyma. So we want to make sure that no matter what happens with the brain, of course, there's not that much space between those two layers. So we want to make sure that those venous sinuses remain open and patent to be able to drain structures. If they don't remain open, you can imagine that there's going to be quite a lot of obstruction. So you need to keep those veins taut, rigid, and patent. The dura mater is one of those layers that actually has a lot of vascularization and innervation, particularly by the middle meningeal artery, which is of a lot of clinical significance, as we'll see later on down the track. And it's also innervated by the trigeminal nerve. The arachnoid mater is, in a sense, quite different. So it's at the middle layer, and it has no vascularization, no innervation. The main important things to remember with the arachnoid mater is the spaces that it forms. So you can see on this diagram here, I've already talked about the dura mater at the very top. You've then got the arachnoid mater, and just underneath, you've got the subarachnoid space, right? So subarachnoid underneath the arachnoid. And that contains all your CSF. So this kind of space here, you don't really see fluid inside. So it's obviously the CSF has been removed so we can better see the structures within the subarachnoid space. But that's where we would see the fluid that helps to cushion the brain. What we can appreciate really well, though, here in red is the arachnoid granulation, specifically like this little grape-shaped thing is called an arachnoid granulation. And that contains small projections of arachnoid that kind of go up into the dura. So you can see it kind of going into those venous sinuses and close to where the dura mater is. And these consist of clusters, so grape-shaped clusters of small arachnoid villi. You may have heard of villi in a lot of different contexts. So, you know, the intestinal villi for absorption. This one is quite similar. It's, in fact, the villi in all parts of the body are kind of there to reabsorb fluids or other nutrients or anything like that. So what this does is it returns CSF back into the venous circulation, And you've got this whole circulation of, okay, it goes into the veins, then it re-enters back into the CSF spaces, and it keeps doing that. This is where that reabsorption happens. So again, we will cover the ventricular system in a lot more detail later on down the track, but they should be kind of seared into your mind the fact that whenever you're thinking about reabsorption, it's going to be through these granulations. And then finally, just underneath all of these layers is the pia mater. The main thing you need to know about this is that it is the only layer that follows the structures of the brain, because it is literally attached to the brain. So if you kind of were to do a dissection of a brain and see a brain in real life, the really shiny layer would be the dura, then you peel it off, arachnoid, peel it off, and pia is very difficult to peel off because it follows all of the fissures and gyri of the brain. So it's kind of part of the brain, tightly adhered to the surface of not only the brain, but also the spinal cord, parts of the CNS, very vascular. And the reason why, of course, is because we need those blood vessels that perforate through the pia mater to then supply the underlying neural tissue. Okay, so that's a very quick overview of the meningeal layers, pretty much everything you need to know on one slide. Let's move on to the dural reflections. So as the name suggests, these are reflections of the dura mater, and it's places where these meningeal layers fold onto themselves. And the reason why, or at least anatomically why it's significant, is because it actually does help to divide the cranial cavity into compartments, which each compartment houses a specific part of the brain, which is really useful because it actually divides, if you're confused about temporal lobe and parietal lobe, sometimes this can really help you to figure out which one is which, if you didn't know already. So the falx cerebri, I should really quickly clarify just to orient ourselves. This diagram is a sagittal section of the head, I guess, with the brain removed and the cerebrum, cerebellum, everything like that removed. So you can only appreciate these dural folds. So the falx cerebri is the biggest one, right? It's the one that separates the right and left cerebral hemispheres. And if you kind of have a look at where it ends up at the very end, remember the ethmoid bone, right? It has the crista galli. The significance of that, and you can see cross-section there, is that it attaches anteriorly to the crista galli. That's where it ends essentially. And at the very back, it ends kind of here, right? Attaching to bone. You've also got the tentorium cerebelli. So this structure here, right? If you have a look at this, these ones are kind of more vertical, whereas these ones are this one is more horizontal. And what that does is it separates the occipital lobe from the cerebellum. In other words, it separates the cerebrum or the cerebral hemispheres from the cerebellum underneath. And it also contains the tentorial notch, which allows for passage of the midbrain. So obviously you don't want to cut off cerebrum from cerebellum. There needs to be some sort of passage for things to go through. You also got the falx cerebelli. So essentially this exact same thing as the falx cerebri as the name suggests, but instead of separating the cerebral hemispheres, it separates the hemispheres of the cerebellum. Very simple. And then you've got the diaphragm sellae. So this little kind of hole here, I guess you could call it, it covers the hypophyseal fossa of the sphenoid bone. And again, as the name suggests, it would house the stalk of the pituitary gland. And then just underneath it, the actual sella turcica would be where the pituitary gland is located. So I guess the main function of these, apart from being quite helpful for an anatomist in terms of landmarks, it's to make sure everything is fixed in position, right? If you had none of these structures, then you would have the brain being kind of free to move around as it wants, and then risk of damage as it hits different walls in the cranium. So that's the main, I guess, function, but there's lots of other functions. Now, in the context of intracranial bleeds, which we will cover in a huge amount of detail later on, I just want you to remember two things. One is that there are bleeds such as SDH, so subdural hematomas, that can cross things like the suture lines, unlike with a extradural or epidural hematoma. But none of these bleeds will ever be able to move across the falx cerebri. So you will see these bleeds being really diffuse, right, along the edges of the cranium, but you will never see them cross across to the other side of the brain because you've got this tough layer in the middle that separates out the two hemispheres. Right, the only real connection you have between the two hemispheres is through this portion here, which I won't spoil yet. You'll cover this a lot more when you cover the brain itself, but there's still a connection here. Apart from that, you don't really have that much of a connection. And then you've got the idea that large bleeds, if they do accumulate extensively, they can push against the falx, and then the falx pushes against or they push against the dural folds. Dural folds then push against the other side of the brain. So even though they can't actually spread to the other side of the brain, what they can do is cause a mass effect where they push against their neighbors and therefore cause damage to the other side of the brain, even though the bleed is located contralaterally. Okay, now let's cover the actual hematomas as I've promised. So you've got three main types. Apart from, I guess you could say intraparenchymal bleeds, but they're not really that important for this meningeal discussion. So intraparenchymal just meaning within the parenchyma of the brain. That's not that important. The main ones we're going to be focusing on are epidural, subdural, and subarachnoid. Now, epidural hematomas, and I guess just really quickly to get this out of the way, epidural and subdural are called hematomas, right? So, and the reason why is because they actually form very defined hematomas, right? Masses that you can actually sort of see on CT scans or MRI scans. Whereas the subarachnoid is a hemorrhage because it's actually more free to be able to move around and doesn't really form a mass. So I guess just get that out of the way. The idea that those H's in the acronyms don't all mean the same thing. Hematoma, hematoma, hemorrhage. Other than that, there's way more differences that are more clinically relevant. So with an epidural hematoma, as the name suggests, epidural, so above the dural layer, it's between the skull and the periosteal layer of dura. The main reason why you get damage or epidural hematoma is because you have damage to the MMA, middle meningeal artery, after usually getting a blow to the side of the head. So as you can see on this side here, you've got some sort of fracture of the skull. You get the middle meningeal artery getting torn, and therefore blood can then enter into this space. Now, the classic region where you get MMA artery damage is on the pterion. Remember that really fragile part of the temporal, or it's not really part of the temporal bone, it's more so the H shape that forms between a couple of different bones on the lateral aspect of the cranium. It's very, very weak. So if you get punched there or a golf, I don't know, a bat or something hitting you on the side of the head, very likely that you could damage this middle meningeal artery. And the reason why this kind of forms a particular shape like it does here is for a couple of reasons. First, it's high pressure blood, right? It's an artery. So it's going to develop very, very, very quickly, right? Quite fast. It forms a lenticular shape, but if you want to be really simple about it, it's a convex shape, right? Some radiologists like to describe it as lenticular. So just imagine sort of like that shape forming. And the reason why is because if you look at these points here, those are actually suture lines. And so those suture lines, because the dura is attached to the suture lines at various points, and because the dura is quite thick and inextensible by itself, it means that the blood is not going to be able to go past the suture lines and therefore will just accumulate within this space. Hence why it's so dangerous, right? It's quite dangerous because it's going to keep building very quickly because of high pressure blood and cause significant damage to the brain, even causing things like midline shift and all those sorts of crazy things you can see on an MRI. So generally the course of events clinically that you need to know is it's a trauma. You have a lucid interval for whatever reason. The pathophys is quite complicated there, but you have a little bit of a lucid interval for a couple of hours, and then suddenly they just go unconscious because of the damage to the brain. Now, the way that I like to remember this is epidural, so epi, so pi. It forms a bit of a pie shape, right? That thing kind of like a pie. Subdural is, I guess you could say, almost a polar opposite to what this is. So subdural, again, below the dural layer. So between the meningeal layer of the dura and then the next layer down, which is the arachnoid, usually caused by damage to the bridging veins this time. So not arteries, we have bridging veins that are, like there's many bridging veins along the surface of the brain, but you have damage to one of them. And because it's very low pressure blood, this bleed takes quite a bit of time to actually get to a point where it becomes symptomatic. And usually what happens is that you have some sort of fall or a shearing force. Sometimes it can be atraumatic. But the point is that it forms a semi-lunar shape. So kind of like a moon, essentially, or a half moon or a crescent or something like that. The shape is concave. And this is because this time, this layer of the dura is not fixed by the suture lines, right? Because it's not actually attached to the bone. So it can spread out almost as much as it wants, right? Apart from, remember we said, it can't cross the falx cerebri. So that's the only limiting factor. Otherwise, it can spread as much as it wants. And so you get this very slow bleed. So you get a bit of a headache, and then they will slowly deteriorate. And sometimes you might not even realize that they're going into or they're having a hematoma, like with an epidural hematoma, which can be quite obvious. And the way that I like to remember this is subdural, so sub-banana dural. It has a shape of a banana or like a crescent. And then finally, subarachnoid. Essentially the thing you have to remember here is just below the arachnoid. So you now are entering the space of sort of the pia mater. And so the blood can go and follow any part of the brain contours that it wants. So it's described as having a diffuse stellate shape, and you can kind of appreciate that down here. It kind of just follows the brain wherever it goes. Usually from a rupture of an aneurysm, arteriovenous malformations, or because of trauma. And the main thing to remember here, pathognomonic, is the sudden onset thunderclap headache. Okay, so anytime you see that, you're thinking, okay, I need to rule out a subarachnoid hemorrhage. And some other signs that you can get are high ICP, because it's obviously increasing the intracranial pressure because of the bleed. And you can get meningism because the blood actually irritates the meninges. And remember, the meninges actually do have some innervation. So you can get things like stiff neck, just reflexively. And you can also get photophobia and headaches, as we mentioned. Okay, so that's really important to remember. And I guess just with subarachnoid hemorrhages, you can see there's a significant overlap between the clinical picture of that and a meningitis. And the main thing that separates them is, obviously, apart from investigations and so on a clinical assessment alone would be the presence of a fever, right? So you probably wouldn't expect a fever with a subarachnoid hemorrhage because it's not a inflammatory process. And of course, I kind of mentioned the fact that if you do have a mass that's located, if it's blood, if it's a tumor, whatever it is, that mass, if it keeps growing, it's going to cause a shifting of the brain structures and some other structures within the cranial cavity, because it is a very fixed space that doesn't have too much volume for extra things to be there. So one of those space occupying lesions is a bleed. So if the bleed, especially within MMA rupture with very, very fast buildup of blood, it can cause structures to be pushed out. So some of the herniation syndromes we can talk about are supratentorial and infratentorial herniations. So supratentorial is above the tentorium, so above the tentorial notch more specifically, and you've got four main types. Now I've forgotten to put a diagram here, which is very not smart of me to do, because the diagram does help quite a bit. So I apologize for that. But if you look at the notes, you'll find the diagram there. Or even if you search online, there's a really nice diagram somewhere online. So you've got subfalcine, which is the frontal lobe pushing underneath the falx cerebri. So I want you to just think about this being like this part of the brain kind of pushing underneath and then going across to the other side. That's essentially what it is. So you get things like a midline shift, which is a deviation of the falx. So this falx cerebri gets pushed across, and you also get effacement of the lateral ventricles. In other words, the ventricles in the middle, they look like they're being squashed, right? Which can lead to things like hydrocephalus, because you have a buildup of CSF that's not able to be drained out effectively. That's probably the most important one to remember in terms of the signs and the picture of what that looks like. Central herniations, movement of the brain across the tentorium cerebelli. So this is a downwards motion. Uncal herniation, you'll see this very often. The temporal lobe moves inferiorly and therefore squeezes on the midbrain. So that can be very, very acute emergency, because midbrain is responsible for a lot of these really important functions, which we'll get into in neurophysiology. Transcalvarial is very easy. So you just have some sort of hole within the cranium, and then the brain herniates through that. So classically, the one that you will hear about is if you have someone with a raised ICP, so raised pressure within the cranium, and you're doing something like a burr hole, or you're trying to essentially make a hole in the brain to be able to decrease pressure. Sometimes you can have the brain, because now everything's coming out, the brain can actually herniate through. So that can be, iatrogenic in a sense, but it can also be because of a fracture or something like that. Infratentorial, the main thing to remember here is that, of course, below the tentorium, but some phenomena you can get is a tonsillar herniation, which is essentially the tonsils of the cerebellum going through the foramen magnum, the big hole at the bottom of the brain, bottom of the cranium. And it leads to a coning phenomenon. So remember that these sections of the midbrain are very, very responsible for things like breathing, heart function, and those sorts of things that are very vital to life, right? Ventilation, etc. So you can very quickly get cardiorespiratory arrest and then eventually death. So things to be mindful of. And again, have a look at a diagram somewhere, which will show you all of these in context. Okay, now let's get to the brain itself. So we've done enough, the peripheral stuff. Now let's actually look at what the brain is made of. Now, there's not really too much in terms of like really studying the different lobes of the cerebrum and really being able to understand what the functions are, because as you can sort of see in this diagram here, and especially with the caption, it even says the list of functions are by no means exhaustive. So while this is a really good diagram, I think that you can never get to a point where you know exactly all the functions of each of the lobes, but I think it's still a good idea to know roughly what you're dealing with. So I guess what I'm not going to do here is cover the functions. That's more in physiology, but I just want to cover the actual lobes themselves. Easy thing is, these are all sort of, I guess you could say, named after the area of the cranium in which they're under. Realistically, I think it's probably the other way around. But anyways, what you have is frontal lobe, right? So that's especially like kind of the more obvious one. It's at the front. You've got the parietal lobe, which is on either side. So parietal lobes. You've got the occipital lobe, which is all the way at the back. You've got the temporal lobe, which is again on either side, but it's kind of more inferior to the parietal lobes. And then if you kind of retract away the frontal lobe and the temporal lobe, you can uncover this thing called the insula, which some people call as part of the temporal lobe, but again, I would just treat it as slightly different, not that important to really remember at this stage. And then if you're looking for something a little bit more realistic, here you go. Now, of course, on these diagrams, they've been very nice in terms of actually drawing out all of the borders. But when you get a real brain in a dissection, it's going to be really difficult to actually definitively say, this is where the temporal lobe ends and this is where the parietal lobe ends. But what's really important for you to be able to identify is the main sulci of the brain, the major sulci of the brain. So the first major one I want you to think about is the central sulcus. So this green one here that kind of goes like this. I know that technically this has been covered by a green line, so it's not very helpful to see the actual sulcus itself. But if you see a brain and you see, if you're able to follow a line that goes from the temporal lobe region all the way up to the top of the brain, that tells you that it's the central sulcus. Every other line will terminate at some point because it keeps winding around the different areas of the brain, okay, or the different extensions of the brain. The lateral sulcus is probably the easiest one because you can sort of see how it separates off the temporal lobe from the frontal and parietal. And you can actually squeeze your fingers in here and separate out everything as it's been done over here to really reveal the insula. You've got a huge number of other gyri sulci that exist. I don't think any of them are particularly relevant for you to know, but if you can identify these two, that does most of the work for you in terms of figuring out frontal, parietal, and temporal lobe. And then occipital lobe is just it's a bit more obvious because it's just going to be whatever's at the back. Okay, and again, here's a diagram looking at it from medial and lateral views. Now, the lecture goes into quite a bit of detail about some of the ways you can describe regions of the brain, so cortical regions. I think this is kind of going into a little bit of physiology, but not so much because you're still focusing on regions. This is probably not as high yield as just knowing the lobes themselves, but I think it's just a good idea to understand what these terms mean, especially the primary cortical regions. So the major ones you will cover in physiology are the primary motor region and the primary somatosensory region. Primary motor is in the precentral gyrus. So again, remember I said the central sulcus here? So before that, so remember when we say pre-central, I know it sometimes means behind, but if you imagine a patient is standing in front of you looking at you, pre would actually mean at the front of the patient. Does that make sense? So pre for you, right? Because it's closer to you, but for them, because they're facing you, it's actually ahead of the sulcus. So it's confusing, but get used to the terminology, okay? So it kind of helps. So precentral gyrus, that is where you get the primary motor cortex or primary motor region. And the primary somatosensory region is the postcentral, so behind or for you in front of the central sulcus. Very confusing, but it does make sense as you kind of use that terminology more and more and more. You've also got some other cortical regions that are kind of a primary function. So you've got a primary visual, primary auditory, primary olfactory, and I've listed the specific lobes that they're found in. But I think it's also just easier to have a rough idea based off this color-coded diagram of where things are located. So for example, auditory, it's located on the temporal lobe. Okay, you've also got the visual. I think this is the easiest one to remember. It's going to be around the occipital, and then you've got the olfactory. So you can't really see it on this diagram here, but you can see it right there, primary olfactory region. That's going to be located on the temporal lobe as well, but just on the inner surface. The least important ones are the unimodal and multimodal association regions. Unimodal association means it just incorporates information from one lobe and only one lobe. So you've got the motor unimodal association regions, the premotor, supplementary motor regions, which are all highlighted on this diagram here. And you've got the sensory ones, the auditory, visual, somatosensory areas. This is actually, again, much more important for physiology, not so much to know where they are, because there's no real sort of anatomical landmarks to tell exactly when these areas end. Just know that they exist. And then multimodal, this is where it gets kind of crazy. These areas incorporate information from many different lobes. I would say this is a little bit more important. So prefrontal, so just kind of, I guess you could sort of see it here, right? You've got these two diagrams here. So the prefrontal region, so just at the front of the frontal region, I guess you could say, that's where you have areas like Broca's region, which is responsible for execution of speech. In other words, articulating speech. Again, you cover this in a huge amount of detail in physiology, so don't worry about it too much at the moment. You've also got the parietal temporal occipital region, which is just a fancy way of saying it goes across all of those lobes. And that includes an area called Wernicke's region, which is responsible for the other side of Broca's region, which is comprehending speech. So one is responsible for making speech, one is responsible for understanding speech. And you can get a lot of different conditions called aphasias, where you can have damage to either Broca's region, Wernicke regions, the region that connects both of these two together, or other parts of the brain that leads to difficulties with this speech pathway. But we won't cover that today. And then the limbic lobes. So you've got limbic lobe here on the temporal lobe, but you've also got other limbic regions that are, of course, on the temporal lobe, but also just pretty much go through every part of the brain, mainly just around the cingulate gyrus, which is that part of the brain which I've alluded to previously, which kind of connects both hemispheres together. So that is important for emotion. But of course, it's difficult to really, even search it up on Wikipedia, limbic lobe, there's a lot of debate in terms of what sort of parts of the brain it includes. So I wouldn't be too fussed with knowing the exact details of that. Just be familiar with the fact that these exist. And you will cover this in a lot more detail in physio. Okay, and then just quickly moving down to the spinal cord. We don't want to leave this behind because spinal cord is equally important. Just a quick word on cross-sectional anatomy. So you all know about the spine already. You know that, of course, this is showing the actual spinal, like the vertebrae themselves, right? But what I'm really trying to get at is the actual spinal cords. So you got, C1, C7, T1, T12, L1, L5, S1, S5. The main thing to remember is that, remember, you've got 8 cervical roots rather than 7 as you have the number of vertebrae here. But otherwise, this should be revision from, musculoskeletal anatomy and some neuroanatomy from there. The main thing to focus on here is if we were to take a cross section of the spine, what kind of things would we see, especially if we did staining, microscopy, and all those other extra fancy things. So I think the top one should, again, sort of be revision from first year. You don't need to know as much detail as you did in first year, but it's a good idea to know what these terms mean. So you've got the dorsal horn, dorsal meaning at the back, right? So dorsal horn there, and that's going to be responsible for the sensory functions. So it's going to be an ascending pathway. So it goes from the sensory neurons to the brain, and the cell bodies are located within the dorsal root ganglion. So this little, I guess you could say, inflation or expansion of the neural centers, that's called the DRG. You got the ventral horn, which is at the front. So that's responsible for motor neurons. So you got those cell bodies within the ventral horn. They're descending pathways, so they will eventually end up on innervating typically muscle. And so an extra thing I'm not sure we would have covered in first year is the lateral horn. So just kind of between those two in this little spike here, that's where you end up with another type of neuron, which is responsible for autonomic control. So that's mainly to the visceral structures like organs and that kind of thing. You'll notice that it kind of undergoes this separate pathway. So it goes across here, travels through here, synapses across, goes through here, etc., etc. So the white rami communicans, gray rami communicans, all that stuff happens here. But again, not too important to understand at the moment for this particular portion. Then you've got the actual nuclei. So if we really go into detail and take out this piece of matter and actually stain it or have a look under microscope, we can actually see different regions. Now you've got laminae, which are, I guess, numbered in Roman numerals from 1 to 9 or something like that. But that's not the important, or 1 to 10, sorry, not the important thing to understand. The main thing here to understand is the nuclei, because that actually gives you a picture of what the functions are. So the substantia gelatinosa, this top bit here, is responsible for pain and temperature sensation. So this is where those neurons will traverse through. The nucleus proprius, this little other blue section here, is responsible for sensation of mechanical touch as well as temperature. The dorsal nucleus of Clark, so this little bit here, is responsible for proprioception. The IMN, or the intermedial nucleus, so this bit here, this green section, as we discussed, it's basically where that lateral horn is. That's going to be where autonomics and visceral sensation really takes authority. And then you've got the motor neuron centers, right? So again, within this ventral horn, those innervate visceral tissues and skeletal muscles. So really, these two bottom ones are very easy to remember. The top ones are a little bit more specialized because different sensations go through different nuclei, as it kind of makes sense, right? Because what we'll see later on is that they eventually need to end up in different tracts so that your brain is able to differentiate what is responsible for pain, or what's conveying pain, and what's conveying mechanical sensation. Okay, now let's go to the tracts. This is probably why you're all here, really decoding what each of these tracts are. Remember that you've got descending tracts, mainly responsible for motor function, and then you've got ascending tracts responsible for sensation. So in the descending tracts, you've got the pyramidal tracts. We'll kind of cover why they're called pyramidal tracts in a sec, but one of them is the cortical spinal tract. So that innervates voluntary muscles of the body, and it stays on the ipsilateral side. So again, if you don't remember anything from this particular slide, just remember that it goes to voluntary muscle and it just stays on the same side. So if you have some sort of pathology, you would expect it to be on the same side as where the lesion is, essentially, to a point. So you got the first order neurons, and I've got the diagram here. I've got one stylized picture and then one that I've drawn from the lecture itself. I would recommend you draw these out too, as like you follow the lecture, because it really helps consolidate some of these really complex ideas. So the first order neuron, as you'd expect, it goes from the brain, so the specific part of the cerebral cortex, down into the ventral horns found in the spinal cord. So very easy to remember that. The input or receives input, the cerebral cortex receives input from the primary motor cortex, the premotor cortex, the supplementary motor area, and also the somatosensory region, which helps to regulate the ascending tracts. But essentially, just if you want to keep it simple, remember primary motor part of the cerebral cortex, responsible for some of the execution, goes down into the ventral horns. Before then, it does a couple of really interesting things. So first, and I'll focus on this diagram here for the time being, because it's focused on the cortex, goes down, all of those fibers converge into the internal capsule. So the internal capsule is basically just a white matter pathway between the thalamus and the basal ganglia. And just a quick bit of clinical relevance, because it doesn't really come up a lot later on, but the capsule is very prone to stroke during hemorrhages. So I want you to try and think about, by the end of this slide, if you have a capsular stroke, what sort of impact is that going to have on a person in terms of motor function, at least? From there, it then passes through the crus cerebri of the midbrain, and then it goes down to the pons, and then eventually ends up down in the medulla. Okay, so remember that you've got these pyramids, right? So within the medulla, that's why it's called the pyramidal tracts, because it eventually ends up in the pyramids of the medulla, and then it splits into two. So all this time it's together. Eventually it splits into two, 1, 2, like that. And you've got essentially now two tracts. You've got the lateral corticospinal tract. So that's the one that goes across, that decussates, or essentially decussate, meaning goes to the other side, to the contralateral side. And then the anterior corticospinal tract, which continues down, stays on the ipsilateral side of the body. Now, as you can see from this diagram here, I'm not sure how well this has come up, but you can see that most of the fibers go to the lateral side. So that's really important to remember, whereas a few of them will stay on the anterior, or I guess stay on the same side as where those fibers originated in the cerebral cortex. So you might be confused when I've said, oh, it stays on the ipsilateral side. What I mean is, when I say it stays on the ipsilateral side, I'm talking about within the spinal cord. So remember that when you have pathologies, most of the time it's, okay, you have damage to the spinal cord at this point. Where do you expect symptoms to be present? So what I'm saying here is that most of the time, because the fibers are only going to be on this side, if you have damage to the spinal cord at any point, what's going to happen is that side of the body is going to be affected. Of course, if you have damage to, say, like up here, that's a completely different story, right? Because you will have damage to both of those tracts, not just the one that's on the same side. So hopefully that makes sense. So whenever I say ipsilateral, contralateral, I mean within the spinal cord. Okay, from there, the second order neuron takes that, so it synapses with the neuron that came down to the ventral horn. So all the way down here, that then goes to a new neuron, which goes down to the muscle. And the lateral ones typically go down to the muscles within the limbs, whereas the anterior ones go to control the trunk, neck, and shoulders, which again makes sense based off the name. Lateral to the limbs, anterior more for the middle section. So that's the cortical spinal tract. The less important one is the cortical bulbar tract, which is also a part of the pyramidal tract system, but this time it innervates voluntary muscles of the head and neck through the cranial nerves. Notice here that I haven't said anything about ipsilateral, contralateral, and I'll get into that, into the reason why. But again, once you cover cranial nerves, you'll understand some of the clinical, I guess, picture that you can see if someone has damage to the cortical bulbar tract. But for now, I just want to cover the basic anatomy. So you have the first order neuron, as we did before in the corticospinal tract. They go from the lateral aspects of the primary motor cortex, so a lot more lateral than with the cortical spinal tract, so all the way across the side. They converge again through the internal capsule, so think about what could happen if we have damage there, through to the brainstem. It then terminates on motor nuclei of the cranial nerves at various points within the midbrain, and you will cover this in a huge amount of detail at some point, but they'll synapse onto them. And then eventually, most of these fibers actually have bilateral innervation. In other words, if my motor neuron goes down to a cranial nerve nucleus, then you will actually have that nucleus giving rise to the left and the right aspects of the cranial nerves. So for example, this is a good example to contextualize. The left motor cortex will give rise to both of, or will innervate both of the left and the right cranial nerve 4, for example, here. However, there are two very important exceptions to this rule. And by very important, I mean that they actually have clinical manifestations, which we'll cover later on down the track. One is the lower face. So the upper motor neurons only go to the contralateral cranial nerve 7 nucleus. The upper half of the face has bilateral innervation, which has a lot of implications for things like Ramsay-Hunt syndrome, that kind of thing. But over here, remember that the lower half of the face only has like unilateral innervation, and it's mostly on the contralateral side, so the opposite side. And then the tongue has, well, it technically is more bilateral, but the upper motor neuron more strongly tends to innervate the contralateral cranial nerve 12 nucleus. Okay, so that's especially to the lower part, which controls, or the lower part of the nucleus, which controls the genioglossus muscle that innervates, act in the tongue. And then, of course, same as before, second order neuron synapses onto the lower motor neurons, carries the motor signals to the muscles of the face and neck where they do their functions. And then you've got the extrapyramidal tract. So they don't work through the pyramids, and they're mainly responsible for involuntary and automatic, or sometimes, yeah, basically automatic muscle control, like with tone, balance, posture, or motion. So on the right-hand side, you've got a really nice diagram that summarizes the difference and the different tracts that are involved in each. This is probably the lowest yield thing to know, but I've seen about 2 or 3 questions come up on some of these tracts. So if you just want to remember like 1 or 2 words from each of them, I think it does help. And it's especially easy if you know what each of the words themselves mean. So for example, you've got ipsilateral and contralateral tracts. So ipsilateral means it does not decussate, stays on the same side. Contralateral goes across. The ipsilateral tracts include vestibulospinal. So vestibulo, it should tell you something about, this is something to do with balance. And you've got medial and lateral tracts that arise from the vestibular nucleus. So again, as I said, responsible for balance and posture, and they mainly go down to innervate the anti-gravity muscles, which are the arm flexors, and the leg extensors, which essentially just keep you standing and from falling under the influence of gravity. You're not really consciously thinking about standing upright and not falling over, so that's why it's taken control by the extrapyramidal tracts. And then you've got reticulospinal tracts, which also have a medial and lateral aspect, but they actually have very different functions. So the medial aspect comes from the pons, and it increases voluntary motion and muscular tone. Whereas in situations where you don't want that, the lateral tract, which comes from the medulla, it actually goes and relaxes those muscles. So reduced voluntary motion and reduced muscle tone. The contralateral tract, the major one to remember here is the rubrospinal. So rubro means red, essentially, I think. So that's going to be responsible, or that's going to be from the red nucleus of the midbrain. And it goes down to control the fine hand movements. So hand coordination, that kind of thing. And then the tectospinal comes from the superior colliculus. Again, you'll cover the colliculus and what that means later on, but it goes from the superior colliculus with the midbrain, which then receives the optic nerves, and therefore it's actually responsible for reflex head movements in relation to vision. So if you see something and your head moves along with it, so your vision and your head movements working together, that is responsible, or the structure responsible for that is the tectospinal tract. And again, just to reinforce, the extrapyramidal tracts are not from the pyramids. They originate in the brainstem rather than from the cortex. So less important, but I think just know some detail about each of these tracts, and that'll get you a long way, just in case questions come up in the exams. Now, the more important ones are the ascending tracts, so the things that take sensory information. If you've done some like clinical skills on neurology and peripheral nervous system examinations, some of these tracts may be already quite familiar to you. And I think in first year physiology, they do cover this to some extent, but here we go into a lot more detail. So the first important one is the DCML pathway, so the dorsal column medial lemniscus pathway, and that is carrying fine touch, vibration, proprioception, and it stays on the ipsilateral side of the body. Remember, again, I'm talking about in relation to the spinal cord, because eventually, as you can see in this diagram, there is a crossing over, but at least within the spinal cord, it stays on the same side as the sensory fibers from which the signal originated. So first order neurons, I should actually clarify very quickly. With the motor pathways or the descending pathways, we tend to only have two nerves, so first order, second order. With the ascending tracts, you tend to have three orders, so first order, second order, third order. So just as a general rule. So let me get back to this, DCML. The first order neuron carries signals from the peripheral nerves, wherever they were, down towards the medulla oblongata. So it goes to the medulla oblongata. From there, or I should say, you've got the upper limb versions, and then you've also got the lower limb versions. So you've got the upper limb, which is responsible for everything above T6 level. That's a really good landmark to remember. And that goes towards the fascicular cuneatus, which is this sort of structure here. So this part here, which again, you will cover in midbrain lectures a lot more, but that will be on the lateral side of that particular part of the midbrain. Whereas the lower limbs, covering everything below T6, goes to the fascicular gracilis, which is more on the medial or closer to the midline of that particular part of the midbrain again. An easy way to remember this is that you've got a gracilis muscle in your lower limbs. So obviously gracilis will be responsible for lower limb function. And the way to remember that it's located more medially in a cross section is that if you have someone standing in a T pose, basically like that, standing up, you will see that the legs are in the midline, whereas the arms are more lateral. Okay. Second order neuron then goes from these sections, so the nucleus cuneatus or gracilis of the medulla to the thalamus. So that decussates within the medulla to the contralateral medial lemniscus. In other words, it crosses over and then it goes up towards the thalamus. And then that third order neuron from the thalamus goes to the same-sided primary somatosensory cortex. And again, when I say same-sided, I mean in relation to the thalamus, right? So it's on the same side there. But overall, it actually goes over to the opposite side of the brain. And specifically goes through the ventral nucleus or the posterolateral ventral nucleus of the thalamus through the internal capsule, again, internal capsule, super important, to the brain. You've also got the spinothalamic tract, which is responsible for pain and temperature, sensation, crude touch, and pressure. And that crosses over immediately to the contralateral side in relation to the spine. So what you can see is you've got your first order neuron. I'll cover it in order. So first order carries the signal from the peripheral nerves to the dorsal horn, as was done with the DCML pathway. So same so far. But then it travels through this thing called Lesueur's tract. So I've just drawn a little circle there. Is supposed to represent what Lesueur's tract is. And then into the substantia gelatinosa, so the SG here. The important thing here is that some fibers from the Lesueur's tract actually go up one or two levels before they then synapse off. So this diagram is not representative of this. What actually does happen is sometimes you have the fiber coming in, it actually goes up a level or down a level or a couple of levels, and then it goes through the same pathway, but just at a different spinal level. Why is this important? Well, if you have damage to this particular system, So let's say if you have damage to the nerve here, you might still have pain and temperature sensation from this level, making its way to the brain because it actually found a way to bypass this spinal level and go through another sort of level, right? So that's why it's super important. And we'll get to that when we cover hemisection and why sometimes pain sensation and temperature sensation is preserved. So just remember that for now. The second order neuron then goes from that substantia gelatinosa through to the spinal cord. It crosses over, so it decussates within and at the level of the spinal cord. And then it kind of travels up to the thalamus, but through two different tracts. So you have an anterior and you have a lateral tract. The anterior spinothalamic tract, and sometimes it's called the anterolateral spinothalamic tract. So you've got the anterior part, which is crude touch and pressure through A beta fibers. And then you've got the lateral tract, which is pain and temperature through the C fibers. That's probably the more important one to remember. And then the third order neurons go from the thalamus, the thalamus up here to the ipsilateral primary somatosensory cortex, again through the same pathway as we had with the DCML system. And again, probably the lowest of the lowest yield tract to remember. I've only ever seen one question maybe on this, and if you miss the question, it's totally fine, to be honest. But if you want to remember it, go for it, right? So you've got the spinocerebellar tracts, which are mainly responsible for unconscious proprioception from muscles to the ipsilateral cerebellum. In other words, it is responsible for position sense of where the muscles and different limbs and stuff are located. And it ends up on the cerebellum that's on the same side as that particular limb. So you've got the posterior tract, which is responsible for lower limb proprioception, goes to the inferior cerebellar peduncles, which peduncles will be covered later on, reaches into the cerebellum. The anterior tract, again, from the lower limbs to the superior peduncles this time. And the interesting thing about the anterior tract, which I think is probably the only important thing to remember here, is that it goes through this weird pathway to end up on the ipsilateral cerebellum. So it actually crosses over at the level of the spinal cord, goes up, 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 and then it crosses over again to then reach the same sided cerebellum. So for all intensive purposes, it just does what every other tract does and stays on the same side. But actually, if you look at it further, it crosses twice. So that's why it ends up on the ipsilateral side. The cuneo-cerebellar tract is from the upper limbs, eventually reaches the inferior cerebellar peduncle, and the rostral tract, still upper limbs, but this time the superior cerebellar peduncles. So I won't waste your time too much on this one, but I think if you just want to have an idea of the combinations, right? So which ones go to the inferior peduncles and which ones are responsible for upper limb, which ones are responsible for lower limb. Now the spinal cord reflexes, again, the pathophys of this should be revision. So remember with the spinal reflex, or with any spinal reflex, essentially, you have a sensory neuron that takes the stimulus in. You then have an interneuron or a relay neuron, and then eventually goes on to a motor neuron, and that has an effect on a muscle. The main idea of this is why it's called a reflex, is because it kind of just all happens in the spinal cord. Eventually, you will have a signal that goes to the brain, but that happens after this reflex arc has happened. So for example, touching a pan that's hot, your hand will be taken off immediately, and maybe after a couple of milliseconds will you feel the pain, because your body doesn't want to waste time with getting rid of that particular harmful stimulus or a pin or something like that. In this case, we're not talking about harmful stimuli. I'm more talking about clinical examination, right? So a lot of these you will have covered in your clin skills lectures. But here is just to consolidate exactly what the anatomy behind it is. So I've got the nerve roots, I've got the particular reflex arc name, and then I've got the nerves involved, as well as a mnemonic that really helps to seal the deal if you're having trouble remembering. So remember, the easiest way to think about this is you can see you got like 1, 2, 3, 4, 5, 6, 7, 8. So you got a nice order to it. With 1, 2, it's S1, S2. So within this, the sacrolumbar plexus, lumbosacral plexus, I should say. That's responsible for the Achilles tendon reflex, and it's through the tibial nerve. So if you remember your nerve roots, tibial nerve has from S1, S2, and a couple of other nerve roots. And an easy way to remember this is buckle my shoe. So S1, S2, buckle my shoe. That's responsible for Achilles, because remember, buckling your shoe needs you to kind of go like this with your foot, dorsiflex upwards. L3, L4, which is responsible for the patellar reflex through the femoral nerve. And the easy way to remember this, patellar reflex is probably the most obvious one. Like if you've seen it, and you know what it looks like. But if it's still difficult, remember L3, L4, kick the door. So kicking the door leads you to go like this with your knee, extending your knee outwards. Of course, I'm using my arm for all of these, but just imagine this is the lower limb. C5, C6 for biceps through the musculocutaneous nerve that innervates the biceps brachii. An easy way to remember this is pick up sticks. C5, C6, pick up sticks. So you're going like this, so flexing your biceps. Should be noted that the C6 nerve root by itself, if you take it in isolation, it controls brachioradialis reflex, which is actually through the radial nerve. Less important, but it does get tested in clinical examinations if you're particularly interested in that reflex and that nerve root. And then C7, C8 is responsible for the triceps brachii reflex, which is through the radial nerve. And again, if you're having trouble remembering what triceps does, remember C7, C8, lay them straight. So this is a kind of like an extension to the biceps one, right? So C5, C6, pick up sticks. C7, C8, lay them straight. So kind of drop them out again. And that's, remember, it's flexing and then extending your arms or your elbow. Now let's get to the spinal syndromes. So the main one you want to focus right now on is the Brown-Séquard syndrome. There are many other spinal syndromes like anterior spinal syndrome, posterior spinal syndrome, all sorts of crazy things. But for the purpose of this lecture, the Brown-Séquard syndrome kind of really helps to consolidate everything you've just learned about of the different tracts. So what is Brown-Séquard syndrome? It's also known as a hemisection syndrome or spinal hemisection, which is essentially complete loss of one side of the spinal cord. You don't really ever see pure Brown-Séquard syndromes, but you can see, I guess, pseudo hemisections where a lot of one side of the spine is damaged, and you can see parts of these clinical signs, but it's more for theory that it's helpful. So commonly through penetrating wounds of the spine, including gunshots or stabbing. And the three main tracts that are going to be affected, or the ones that we're going to be focusing on, are corticospinal, dorsal columns, and the spinal thalamic tract. In other words, you've got one motor pathway, and then you've got two of the major sensory pathways that we're going to be focusing on. So if you look at the corticospinal tract, that's responsible, remember, for ipsilateral movement in relation to the spinal cord. Remember I said it stays on the ipsilateral side if you're considering damage within the spinal cord itself. Anything higher than that, firstly, it's very rare to have something higher, like at the level of the brain. At that point, it's very different. But here we're saying ipsilateral movements are going to be affected. So at the level of the spinal cord, you have flaccid paralysis because you have a loss of motor neurons. In other words, those muscles just become useless, right? They're not able to move at all. So that's at the level of the spinal cord. But interestingly, below the level of the spinal cord, what happens is that you have loss of the inhibitory neurons. So remember that in the motor pathways, I'm not sure if you've covered this yet, and you probably will at some point if you haven't in physio. Remember that with the motor pathway, you have these, like motor pathways are always ascending, but you also have a descending pathway that inhibits movements to make sure that movements are not happening, too erroneously or excessively. If you have any muscles below the level of the lesion, that means that you've affected the inhibitory neurons that are going to those muscles or on their way to the muscle. So essentially, those inhibitory neurons are lost. And what happens is that because there's only excitation of the muscle, you get spastic paralysis. So again, the muscle is useless, but it's not like floppy anymore. It's actually just contracting, right? Continuously contracted, so it becomes rigid. So that's what's being shown in the diagram sort of over here. So you have at the level of 1, which is supposed to be where the particular damages happen, you have flaccid paralysis. And then underneath that, you have spastic paralysis throughout. Okay, so hopefully that makes sense. Now the dorsal columns, remember, which are responsible for fine touch, vibration, proprioception, and all those sorts of non-pain and temperature related things. You will have ipsilateral loss of sensation because all of the things within the spine are ipsilateral. So you will have a loss of those particular sensations, which again is covered in that same territory of 2. So if you want to remember, 2 is not just spastic paralysis, but also no vibration, no proprioception, no fine touch. That helps a lot. And then spinal thalamic pathway. This is a really interesting one. So remember that you have spinal thalamic is contralateral, so it crosses straight away as it goes through the spinal tract. So you will have contralateral loss of pain and temperature sensation. So on the other side here. But the cool thing is that you'll see this block here, which, this is at the spinal level of the spinal damage, but still this part is fine. And the reason why is because this part here that was supposed to have been damaged, some of those fibers, remember, go through Lesueur's tract and kind of go up a few levels. So their signals are probably still going to be able to reach the brain, right? So say like this section here, you get fibers that have somehow managed to cross up through the osseous tract and then go through a different spinal level up to the brain. So you still get sensation, but it's only really for about 1 or 2 levels, after which point you will have loss of sensation, definitely, right? So over here, you will have pain and temperature sensation being lost, but relative sparing of a few portions at the level of that particular spinal lesion. So I guess the main important thing here to remember is the 3 tracts, essentially if it's ipsilateral or contralateral, and then try and have a drawing of this diagram, or try and explain to someone, even print out this diagram and try and explain to someone what each of these sections refers to and why this is a gap here and what that means, okay, in terms of the relative anatomy. Supranuclear lesions refer to damage to the upper motor neurons. So far, if I go back to some of these syndromes and stuff, we've kind of looked more at just the lower motor neurons being affected. But I want to now focus on upper motor neurons, so supranuclear. The cortical spinal tract lesions probably a lot more common. Again, I've kind of drawn these diagrams out in quite a bit of detail, but I think these make more sense once you've drawn them yourselves with the help of the lecturer as they take you through each of these topics. But the main thing is that if you have a supranuclear lesion in the cortical spinal tract, you have effects on the contralateral side, and it often tends to be in the internal capsule. So remember what I said here, cortical spinal tract is ipsilateral if you're relative to the spine. But once you get above the level of the spine and looking at upper motor neurons, remember they eventually do cross over. So generally it'll have effects on the contralateral side, most commonly through the internal capsule being stroked out or damaged, because it's susceptible to cerebrovascular accidents. So at the level of the lesion, you'll have muscles becoming weak and low reflexes. And then below the level of the lesion, you will have the same thing as what we saw in the Brown-Séquard syndrome, lost inhibitory signals from descending tracts. So you get that spastic paralysis. Cortical bulbar tract lesions, while they're not as common, I guess, you can still see them with strokes because a part of the brain is stroked out that is responsible for innervating these cranial nerves. Remember what we said about cranial nerves being bilaterally innervated. So most of the time, if you just have a stroke on one side of the brain, you won't actually see any effects in most of the cranial nerves because the other side is still compensating. But remember those 2 nerves that we said are only going to be able to get input from one side, the contralateral side. So that's CNVII, so cranial nerve 7. What ends up happening because of that is you get spastic paralysis within the contralateral lower quadrant of the face. The upper quadrant doesn't get affected because it's still bilaterally innervated. And then you have cranial nerve number 12, which leads to spastic paralysis within the contralateral genioglossus muscle of the tongue. So what happens is that you have damage here. Your tongue muscle on this side undergoes spastic paralysis, so it's contracting, which means that your tongue deviates to that side. So the stroke was here, or the damage was here, your tongue deviates to the other side, so you get contralateral deviation of the tongue, in contrast to a lower motor neuron lesion where the tongue actually deviates to the damaged side, which again, you will cover in a huge amount of detail when you do cranial nerves later on down the track. But that's pretty much it for this particular lecture. Again, a huge amount of detail to cover, but hopefully this has been a concise summary of everything you should know by the end of those 2 or 3 lectures that you'll have. If you do have any questions, remember again that my notes have been linked in the notes section of this particular slide deck. And they're also in the PS Platypus Drive. As always, my messages are always open. I love hearing questions from you guys. It helps keep me on my toes, especially if there's a mistake in the slides, helps me to correct it for future reference. But it also means that any kind of more small details that might come up in an exam are able to be hashed out in relative efficiency. So again, if you have any questions, feel free to hit me up. Other than that, best of luck for your revision, especially for head and neck and especially for neuro. But I know you will have a good time. See you in the next lecture.